All right, let's dive right into this explainer on allergic rhinitis. Today, we're mapping out the actual biological battlefield that takes place right inside the human airway. Whether you're prepping for exams or just looking to sharpen your clinical practice, this explainer is designed to give you a really high-yield, scientifically accurate review. We're going to break down exactly how these airborne particles operate at a microscopic level and, more importantly, how we can mount a highly effective clinical response.
Here's our roadmap for today. We're going to hit etiology and risk factors, the classic clinical tetrad, physical signs and triggers, diagnostic investigations, and finally, wrap it up with the ARIA stepwise treatment plan.
But before we get into treatments, let's set our baseline. When we say allergic rhinitis, we aren't just talking about your run-of-the-mill sniffles. No, this is a very specific IgE-mediated hypersensitivity reaction to airborne allergens. It's basically the immune system massively overreacting to stuff that should normally be completely harmless.
Okay, Section 1, etiology and risk factors, identifying the culprits and vulnerabilities.
So, we can actually divide these allergens into two distinct camps. On one side, you've got your seasonal threats, mostly pollens, that strike at very specific times of the year. On the other side, the year-round perennial invaders. These are the guys lurking inside the home 24/7. House dust mites, mold, animal dander, and cockroach allergens. Figuring out exactly when your patient is getting hit is usually your first big clue in tracking down the culprit.
But you might be wondering, why do some people react while others don't at all? Well, the airway's tolerance gets compromised by a few key risk factors. Patients with an underlying genetic predisposition, which we call atopy, or those with a strong family history, well, they're already starting at a major disadvantage. But environmental factors are a huge piece of the puzzle too. Just living in an urban area with high air pollution significantly bumps up a patient's risk of developing these hypersensitivities. So it's really this 1-2 punch of genetic vulnerability and environmental exposure.
Moving on to Section 2, the classic clinical tetrad. Let's look at the frontline symptoms.
Listen, if you only memorize one thing from this entire explainer, make it the rule of 4. The classic tetrad of symptoms. When you're taking a patient's history, you are actively listening for this exact combo. Intense sneezing, rhinorrhea that is totally clear and watery, not thick, not purulent, nasal pruritus, which is just this intense, driving itchiness, and finally, nasal congestion. Those 4 symptoms literally define the front line of this allergic reaction.
All right, Section 3, physical signs and triggers. Time to spot the clues on the clinical battlefield.
Now, here's a fantastic, high-yield clinical pearl. When a patient, especially a kid, has that constant itchy nose, they'll usually push their nose upward with the palm of their hand to kind of scratch the itch. We actually call this repetitive motion the allergic salute. And get this, over time, that constant upward rubbing creates a literal, visible horizontal line right across the bridge of the nose. Clinically, we document that as a transverse nasal crease.
Another classic visual clue you've probably seen without realizing it, allergic shiners. These are those dark, bruised-looking circles right under the patient's eyes. And no, they are not from a lack of sleep. They're actually caused by chronic venous pooling and congestion right behind the scenes, all secondary to that intense inflammatory response in the nasal cavity. The blood literally just backs up, creating that dark discoloration. Wild, right?
We've also got to keep an eye out for collateral damage. Always check for associated conjunctivitis. You know, those itchy, watery eyes? Another really common feature is a chronic cough, which a lot of the time is driven entirely by this relentless postnasal drip. And when you're taking the history, you have to explicitly ask about timing and location. If symptoms spike the second they wake up in the morning, you should instantly be suspecting dust mites in the bedding. If the symptoms flare up the minute they step outdoors, you're almost certainly dealing with pollen.
Section 4, diagnostic investigations. Let's talk about gathering tactical intel.
First things first, allergic rhinitis is pretty much a clinical diagnosis. It's based heavily on that history and physical exam we just walked through. But if we want to lock down the exact trigger, we escalate to the skin prick test, or SPT, which is hands down the gold standard for detecting specific IgE. Now, what if the SPT isn't available, or say the patient is already on antihistamines that would totally mask a skin reaction? In that case, we just pivot to a blood test. We use the serum-specific IgE, historically called a RAST, to get our hard confirmation. And hey, if you ever need to really confirm the allergic nature of the inflammation at a microscopic, cellular level, a simple nasal smear is incredibly revealing. For allergic rhinitis, that smear will prominently show eosinophilia, highlighting the exact white blood cells that are actually driving this specific type of allergic reaction.
Finally, Section 5, AIRA Stepwise Treatment Plan. Time to build our tactical defense.
The flow of treatment here requires a really logical, stepwise escalation, totally based on how severely the patient is impacted. The golden rule? We always start by reducing exposure. So step 1 is avoidance. Literally, before writing a single prescription, we look at allergen control, things like dust mite covers for the mattress and running HEPA filters. Step 2, if we're dealing with mild or intermittent symptoms, is introducing antihistamines. Step 3 steps it up from moderate to severe disease, bringing in intranasal corticosteroids. And finally, step 4, if all that pharmacotherapy is inadequate and the patient is still miserable, we step all the way up to allergen immunotherapy.
Let's drill down into the actual agents in our toolkit for a second. For those moderate to severe cases, intranasal corticosteroids like fluticasone or mometasone are absolutely your first-line option. They just shut down the inflammation right at the source. Now, for patients who only have mild or occasional symptoms, oral or intranasal antihistamines like cetirizine, loratadine, or levocabastine are super effective. And here is a really crucial strategic tip for you. If your patient has allergic rhinitis combined with concomitant asthma, montelukast, which is a leukotriene receptor antagonist, is an incredibly smart targeted choice because it treats both conditions at the exact same time.
So that leads us to a pretty pivotal clinical question. Medications are fantastic, sure, but they really only suppress the active symptoms. What exactly do we do when maximum pharmacotherapy still leaves our patient suffering? Or what if a patient just doesn't want to rely on daily symptom control for the rest of their life?
Well, this is exactly where we deploy our most advanced intervention, allergen immunotherapy. Administered either subcutaneously or sublingually, this is not just another Band-Aid. This is the ultimate disease-modifying treatment. By exposing the patient to these tiny, super-controlled doses of the allergen, we actually retrain the immune system to tolerate the environment, effectively stopping the reaction before it even gets a chance to start. It really forces us to ask, as we look at the future of allergic disease management, should we be focusing less on fighting the daily symptoms and more on negotiating a permanent peace treaty with our environment? Thank you for joining me on this explainer, and definitely keep that question in mind the next time you see this in your practice.